she also had a fever maximum 38 degrees Celsius and severe pneumonia. At the beginning of the April 2021, she developed a severe sepsis, leading her to ICU admission. At ICU admitted, she needs the oxygen supplement via cannula, and she needs antibiotic with carbapenem and levofloxacin, and she was treated the arthritis. Her arthritis was treated by methylprednisolone at dose 32 milligrams and hydrochloroquine at dose 400 milligrams per day. On 10th April 2021, her pneumonia was stable. Her CBP was normal, and her marker of inflammation, procalcitonin, was 0.16. Her central venous catheter removed, and we discontinued using antibiotic. She needs her oxygen supplement was discontinued. A discharge from ICU, she has been unable to stand alone, and she had painful swelling of her limbs. She was not able to open the top of a plastic mold. At the time of admission, we note asymmetric peripheral motor deficits. Only the right side, and she has rapid muscle atrophy of her both legs and hands. She was right middle nerve palsy and atrophy, left ulnar nerve palsy and atrophy. She has also paresthesia in both foot and hands. This slide, I would like to show her more details of her neurologic examination. So you can see very asymmetrical deficits with two in the right flexor carpi radialis, two at the ABP, at the right ABP, and two at the right tibial anteriors, and two in the gastrocnemius right. Her ROS, so action reflex was bilateral oblique. The quadricep, the bicep, the bicep, and tricep was normal. She had also neuropathic pains at sole and dorsal of her foot, bilateral pain, predominantly on the right side. She had also hypothesia of both soles. The ONLS score was 6. Within this, 2 in the arms and 4 in her legs. Her consciousness was clear and her cognitive function was normal. Her cranial nerve impairment was not detected, and her autonomic nervous function was normal also. This slide, we describe some of her extra-neuro sign. So you can see it's the skin, the livedo reticulis, some of the skin ulcer, and necrotic purpura. Her blood pressure, heart rate was normal. At this time, her saturation, oxygen was normal. And we note at this time, the patient has also the Cushing syndrome because of using the traditional medicine. Here one more time, the picture of the skin lesions with reticulis livedo. So in this slide, we show the detail of the results, the motor nerve study. You can see here the diminution of the amplitude at the median nerve very asymmetrically. There was no conduction block, and the conduction velocity was normal. We could not record any amplitude, motor and amplitude at the tibial, at the left tibial, and left peroneal nerve, but the right, we could record this, but very slight amplitude here. So with the sensory nerve study, we could not record any sensory potential as the lower limbs, but in the upper limbs, there was a diminution of the potential of the sensory potential as the median nerve, as the right median nerve here. Both under nerves, the sensory potential was normal. The conduction velocity was normal for the sensory. In this slide, we show the detail of the electromyography data. So you can see here the address potential address was notable with fibrillation positive shock waves is the dorsal interdorsal, the quadriceps, tibial and anterior rise, the gastrocnemius on the left side. And we note also the decreases of the pattern of quick recruitment. In this slide, we would like to show some the detail of the laboratory test was notable with the high level of CRP here, the high level of rheumatoid factor, and the anti-citrulline circle protein were very high level. The result was notable for the diminution of the ACTH for the Cushing syndrome, and the P and ANCA, C ANCA was normal. The liver P and C ANCA was normal. The antibody with the SSA was negative. At this time, we could not perform this test, the cryoglobulinemia. At that time we could not perform this test. And the marker of systemic disorder contain ANA and anti-DS DNA was negative. So at the beginning, we talked about mononeuropathy multiplex in a patient with rheumatoid arthritis, and some differential diagnosis was vasculitis due to cryoglobulinemia, vasculitis in systemic or overlap syndrome, vasculitis in ANCA syndrome. And I would like to hear your comment.
Okay, no, very nice presentation. Thank you. No, I agree. The clinical pictures of a painful mononeuritis multiplex in somebody with rheumatoid arthritis who then comes into hospital with pneumonia and sepsis. The skin changes, livido reticularis, purpura, very good markers of a vasculitic process. I suppose the concerns I would just be thinking about, well, you know, what about these traditional medicines? Because they can sometimes trigger off vasculitis. I think one needs to be careful about that. There are certain drugs which can trigger off vasculitis. So it's interesting to know that this is a common problem in Vietnam. But that's you can't prove that really. So I would agree this is mononeuritis multiplex due to vasculitis. Now, in the ideal world, you would want to confirm the diagnosis with a nerve biopsy or even a skin biopsy, I think, but that may not be possible in Vietnam, you know.
Yes.
But
yes,
given that vasculitis is a very serious disorder, this needs treatment. And usually what we would consider doing in somebody with vasculitis and perhaps systemic features is think about cyclophosphamide and steroids. I think that's the way we would go, really.
okay.
Was there any kidney involvement at all? Her renal function was okay?
Yeah.
Renal function?
Yep.
Wait, her renal function was normal, Professor.
Okay, so no renal involvement. It's
Okay,
interesting that she
yes.
developed a severe pneumonia. So she must have been sort of affected in some way, unless she had pulmonary infarction and then developed pneumonia on top of that. But no, I agree. This is mononeuritis multiplex. Most likely is immune mediated with the background of rheumatoid arthritis, and she needs aggressive treatment with cyclophosphamide and steroids.
All right, but in this case, we decided to treat the patient with anti-CD20 monoclonal protein rituximab and bolus dose of methylprednisolone.
Right.
At 500 milligram per day. But at this time, we had not evidence of vasculitis because we could not perform the nerve biopsy. You know, this time is so the question was our question can the nerve biopsy change the diagnosis and treatment for this patient?
Yeah, no, I mean, it's a good question in that difficult situation. I think the clinical features are very much for a vasculitis. So I think that we do nerve biopsies, I suppose, because the treatment is so severe in a sense that you want to be absolutely sure that giving somebody cyclophosphamide is the right thing to do. But I think in this situation, one would probably then go for steroids in the first instance. And if they relapse, then you would have to consider other treatments, I think. We use rituximab as second-line treatment for vasculitis, not first-line, partly because it is very difficult for us to prescribe it. It has to be commissioned, it has to be approved, really. Okay. You may have more access to rituximab. I don't know whether you get generic rituximab.
Yes, of course, because in our hospital, the rheumatoid arthritis is sometimes treated by rituximab also.
Yeah.
So after the multidisciplinary consultant, we decide to use this medicine.
Yeah, no, I mean, I know we had a meeting last weekend in Romania with Sudhir Kotaria from India, and they use rituximab much more easily because it's so accessible for them and it's very cheap.
Yeah.
In India,
with some Indian products.
Yeah, and no, I think rituximab is perfectly reasonable because it's also used for renal vasculitis, and I think there was a paper in New England Journal in the last couple of years saying that it was probably as good as other treatments. So I think it would be a reasonable thing to do. How is she done with this treatment? Is she improving? Obviously, improvement is going to take months or years. You know, it's going to take a couple of years before you see any improvement. But I suppose the important thing is that there is no progression of the peripheral nerve deficits. And then, you know, you've suppressed the inflammatory process, and then you can expect regeneration. Were you able to measure complement levels?
Yes, her complement level was the C3 and C4.
Oh, sorry, I missed that. Yeah, no, that's good. Yeah, no, I think I would read vasculitis related to rheumatoid. Aggressive treatment is the right way forward with steroids and rituximab. I don't think I would have any issue about that, really. Uma, I don't know if you've got any comments about that.
I think most of the audience response has also been along the same lines. Most people have suggested mononeuritis multiplex from vasculitis. So I think I'm aware of the time, and also I understand that you have to leave soon. So
yes.
perhaps,
I mean, there's one question about, maybe we can discuss it just in the last minute. Oh, it's 1:10. I'm running late. It's a question of biopsy, really. We would want to biopsy because we can.
Sure.
I don't know whether you would be doing the same thing.
Yeah, I think we do the same thing also, but I think his point is also quite right that even if the biopsy is negative in this case.
Yeah, if you haven't got the facilities, then it is very difficult, I think. You talk about how you set up a nerve biopsy service. I mean, I think the key is okay, you can get a surgeon to do the nerve biopsy. It's a question of preparing the samples and then getting it interpreted by an experienced neuropathologist. Now, whether you can set up some sort of link with, I don't know, Singapore or something where you can get an experienced neuropathologist to do the interpretation, that's very important. So I think it's a neuropathology. The sural nerve biopsy, anyone can learn to do it, and a surgeon can do it pretty easily, really. But it's the preparation of the nerve sample and then interpretation is crucial. How much have you got good neuropathology in Singapore? I know that you have, Uma.
Yeah, so actually we tend to do both the muscle and nerve pathology ourselves. But
you do the nerve biopsy?
Yeah, I think we tend to do it within the department itself. So the neurosurgeons do it, and we tend to interpret it, both the muscle and the nerve. But I think I've spoken to my Vietnamese colleagues before. So muscle biopsy, I think we're working with Dr. Nishino to try to set up a muscle biopsy in Vietnam. But for nerve biopsy, I think sometimes it's good liaisons with the general pathologist, because a lot of times for nerve pathology, we are interested in three main things that are treatable, right? Amyloid, leprosy, and vasculitis. So sometimes the general pathologist may be able to look at this into the interstitial part of the nerve, but when it comes to actual nerve pathology, that's when they struggle.
Yeah, no, I don't know the number of times I've had general pathologists calling a sural nerve biopsy demyelinating neuropathy, because there's the dropout of demyelinated axons, and they call it demyelinating neuropathy. So I agree, if the general pathologist can be appointed and focus on the 2 or 3 diagnoses you've mentioned, I think that would be very helpful.
Yeah, and then just concentrate on the interstitium rather than the actual nerve itself.
Yes, no, I think that's a valid point, and leave the nerve out, because we can tell what's going on in the nerve clinically and on neurophysiology.
Correct, exactly, yeah, that's right.
Uma, I'm going to have to leave because
yes, I understand.
Waiting outside.
Okay, thank you very much, sir. So I think
thank you very much.
We have one more case, but we'll have to let Dr. Manji leave, and please